Hello friend, this is Zubair Khan and you are watching JOURAVI Nursing online classes. This is the part third of the respiratory system. Now we start the part third, the pulmonary contusion. So we will see the here now pulmonary contusion. So what is pulmonary contusion? It is characterized by interstitial hemorrhage associated with intra-alveolar and alveolar hemorrhage, resulting in decreased pulmonary compliance. Okay, so it is an interstitial hemorrhage associated with the intra-alveolar hemorrhage. So the major complication is acute respiratory distress syndrome. So the main major complication of the pulmonary contusion is what? The major complication is acute respiratory syndrome, ARDS. So how we will assess the patient is having pulmonary contusion? So how we will assess? So we can assess first dyspnea, difficulty in breathing. Patient will be restless, increased bronchial secretions, hypoxemia will be there, hemoptysis can be there, and decreased breath sounds, and crackles and wheezing sounds, breath sounds can be heard. So dyspnea, restlessness, increased bronchial secretions, hypoxemia, hemoptysis, decreased breath sound, and crackles and wheezing sounds. Okay, so what are the interventions we needed? So the interventions are maintain the patent airway. So we should maintain the patent airway and adequate ventilation. Okay, always remember, whenever respiratory problem patient is there, we should provide the Fowler's position. Okay, so this is very important. So any respiratory difficulty patient is there, so we should provide the position. Which position? Semi-Fowler's or Fowler's position. The next one is administered oxygen. Okay, administered oxygen. In monitor for increased respiratory distress. So we should monitor the patient for increase the respiratory distress. Maintain bed rest, limit the activity to reduce oxygen demand, and provide oxygen and give fluids as prescribed. Prepare for mechanical ventilation with PEEP if required. Okay, so intervention, we should maintain the patent airway, we should provide the Fowler's position, we should provide the oxygen if prescribed, and we should monitor the if respiratory distress is increased or decreased, whatever. Maintain the bed rest, limit the activity, provide oxygen, give more fluids, and prepare for the mechanical ventilation if required. The next topic is pneumothorax. So what is pneumothorax? So pneumothorax is accumulation of the atmospheric air in the pleural space. So atmospheric air will enter into the pleural space, which result in the rise in the intrathoracic pressure. So entering of the atmospheric into the pleural space is called pneumothorax. It will increase the intrathoracic pressure and reduce the vital capacity or the greatest amount of air expired from the lungs after taking a deep breath. Okay, so like this is the diagram. So this is the pleural space, parietal pleura and visceral pleura. Okay, so outside air enters because the disruption of the chest wall and parietal pleura. So outside air it will enter into the this pleural space, and this air from the lungs it will come in this pleural space. So this is the visceral pleura and this is the parietal pleura. Okay, so in this air will be filled and lungs will be collapsed like this. Okay, So this is the normal lung. This is the normal lung. This lung has been collapsed. So this is called pneumothorax. Mainly pneumothorax means air entry in the pleural space. So next point is the loss of negative intrapleural pressure result in collapse of lung. Okay, so the loss of negative intrapleural pressure. Okay, so intrapleural pressure will be decreased, so lung can be collapse. So what are the pneumothorax? What are the types of pneumothorax? The spontaneous pneumothorax occurs with the rupture of pulmonary valve or small air containing space deep in the lungs. Okay. Next one is open pneumothorax, when an opening through the chest wall allows the entrance of the positive atmospheric air pressure into the pleural space. An open pneumothorax occurs when an opening through the chest wall. Okay, open pneumothorax means opening through the chest wall allows the positive atmospheric pressure into the pleural space. Tension pneumothorax. What is tension pneumothorax? Tension pneumothorax occurs from a blunt chest injury or from mechanical ventilation with the PEEP. When build up with the positive pressure occurs in the pleural space. So this is the tension pneumothorax. It occurs due to the blunt chest injury. Okay, open pneumothorax means when we are going to open the chest wall. Spontaneous pneumothorax occurs rupture of the pulmonary valve. Pulmonary valve means this is the pulmonary valve. This is the when trachea enters into the lungs. This is pulmonary valve. Okay. Okay, rupture of the pulmonary valve, spontaneous pneumothorax will occur. Now assessment. How we will assess? So assessment we will see first. So this is the assessment of pneumothorax. How we will assess? First we will see absent or markedly decreased breath sound. Whether breath sound has been decreased or increased. We will see this. Okay. So first breath sound we will assess whether it is decreased or increased. Cyanosis will check decrease the chest expansions unilaterally. Okay, we will see the like one chest will be fully expand, another will be somewhat distended neck veins. Dyspnea can be there. Patient may go for hypotension and sharp chest pain can be there. Subcutaneous emphysema as evidenced by crepitus on palpation. Subcutaneous emphysema means so there will be an entry of the air into the subcutaneous tissues. Subcutaneous tissues means like chest wall is there. In chest walls there will be some entry of the air. So there will some sound will when we palpate sound will arise. So that is called crepitus. Crepitus. Okay, subcutaneous emphysema as evidenced by crepitus on palpation. Sucking sound with open chest wound. Okay, when chest like this is the chest and open wound is there, so there will be a negative pressure. So their sucking sound can be there. Tachycardia, tachypnea, tracheal deviation to the unaffected side with a tension pneumothorax. So with a tension pneumothorax, tracheal deviation with can be there to the unaffected side. So this is very important. So where tracheal deviation will be there in the tension pneumothorax to the unaffected side. Now another very important point is this one. Client with respiratory disorder should be positioned with the head of bed elevated. I already told you whenever respiratory problem you are facing, we should provide the head of the bed elevated. Okay. Now we will see what are the intervention we can do. So the interventions are diagnosis of pneumothorax. Diagnosis of pneumothorax. is made by chest X-ray. So we can go for a chest X-ray. We will see whether air is present or fluid is present in the pleural space. Okay. Apply non-porous dressing over an open chest wound. Okay, so we can provide the non-porous dressing. Administer oxygen. So this is the first priority. We should administer the oxygen. First priority is Foley's position, then provide the oxygen. Okay, so chest trauma. Provide the oxygen, then provide the Foley's position. Prepare for chest tube placement, which will be remain in place until the lung has expanded fully. Monitor the chest tube drainage system. Okay, monitor for subcutaneous emphysema. Re Review serial chest X-ray result to determine effectiveness of treatment. Okay. Now information of on caring for client is a chest tube. So this we will study in chapter 70. Okay. So for pneumothorax, what we will do? We will go for chest X-ray. We will do a dressing. We will provide oxygen. We will provide the Foley's position, and we will prepare for the chest tube placement and monitor for chest tube drainage system. Monitor for subcutaneous emphysema, and again we will see the chest X-ray whether uh, going patient is taking treatment, so the result is positive or not. So we will check by the chest X-ray to determine the effectiveness of the treatment. Now next topic is asthma. So asthma. So what is asthma? Asthma is a chronic inflammatory disorder of the airways that causes varying degrees of obstruction in the airways. This is a chronic inflammatory disorder marked by air inflammation. So it is marked by air inflammation and hyper responsive to variety of stimuli or triggers. Okay. What are the causes? Recurrent episodes of wheezing, breathlessness, chest tightness, coughing associated with the airflow obstruction. Okay, so wheezing can be there, breathlessness can be there, and chest tightness can be there, and cough can be there. Okay, associated with the airflow obstruction. That may resolve spontaneously. It can resolve spontaneously. It is often reversible with treatment. Okay, it is reversible also. Huh? The severity is classified based on the clinical features before treatment. So it will be classified based on the clinical features. Like status asthmaticus is a severe life-threatening asthma episode. So this is a very important. Status asthmaticus is a severe life-threatening condition. Okay, so this is the life-threatening condition of the asthma. To treatment, and may result in the pneumothorax, acute pulmonary or respiratory arrest. Okay, status asthmaticus is a severe life-threatening asthma episode that is refractory to treatment. Okay, so that is refractory to treatment and may result into the pneumothorax, corpulmonal, and respiratory arrest. The next thing is this is also important point. Whatever is written in red, that is important. Silent breath sounds are associated with the acute asthma exacerbation. Okay, silent breath sound may indicate impending respiratory failure. So this indicates for respiratory failure due to diffuse bronchospasm. So there will be a bronchospasm. Okay, and represent the life-threatening condition. Silent brain sounds are associated with the acute asthma exacerbation. So acute asthma attack is there acute asthma attack is there may indicate the respiratory failure. Why respiratory failure? Because it may be due to bronchospasm. So bronchospasm will be there. So because of that, what can be there? Respiratory failure. So it is a life-threatening condition. Now assessment. What we will assess? First, restlessness. Patient will be restless. Wheezing or crackle sound can be there. Absent or diminished lung sound. Lung sound can be absent or it can be a diminished or decreased. Hyperresonance can be there. Use of accessory muscles for breathing. Patient will use the accessory muscles for breathing. Tachypnea with hyperventilation can be there. Prolonged exhalation can be there, and tachycardia can be there. So this we need to assess. Then another pulsus paradoxus. Okay, pulsus paradox can also be there. Diaphoresis can also be there. And cyanosis. At last, when patient will not get the sufficient oxygen, then cyanosis can also be there. Okay. So what is pulsus paradoxus? This is also very important. Pulsus paradoxus means when the negative pressure has been increased, so there is a overload of the blood into the right atrium. So overload of the blood in the right atrium and less blood supply to the left atrium and left ventricle. So it will lead to the decreased systolic. It will lead to a decreased systolic BP. Okay, so that is called the pulsus paradoxus. Okay, so this is called pulsus paradoxus. And decreased oxygen saturation also. So SpO2 also will be decreased. Pulmonary function test result that demonstrate decreased airflow rates. Okay, so PFT also it will declare that decrease the airflow rates. Interventions. So what are the intervention we will provide for a patient like asthma? First, we need to monitor the vital signs. So a nurse's responsibility. Whenever patient comes with any disease, we need to check the vital signs. Monitor pulse oximetry. Monitor peak flow rate. Administer bronchodilators. What are the bronchodilators? Like salbutamol, ipratropium. These are the bronchodilators. And corticosteroids. Okay, corticosteroid like budesonide and all. Okay, so these are the corticosteroids. Educate the client and family hydrocortisone. Okay, so these are also corticosteroid. Educate the client and family on reducing stress and anxiety and avoid environmental triggers. Okay, for asthma, environmental trigger is very important. Because of environmental allergies only asthma attack can be occur. During asthma episodes, provide interventions to assist with breathing. We should assist the patient with the breathings. Now we should tell the patient how to take the breath. Okay. Then client education. So main important how we will educate the client. Discuss the intermittent nature of the symptoms and the need for long-term management. So we should teach the patient about the long-term management. Okay. So how we will teach? Second point, identify the possible triggers, measures to prevent episode. So we need to identify what is the main possible triggers which lead to the asthma attack. Use a pursed lip breathing. Okay, so pursed lip breathing is very important for COPD or asthma patient. Okay, for asthmatic patient or COPD patient, pursed lip breathing is very important. Okay, management of medications and proper administration. Okay, correct use of peak flow meter and aero chamber or spacer used with inhaler. Wear a medic alert bracelet. So whenever asthma patient is there, we should ask him to wear a medic alert bracelet. So the person should know this patient is related with the asthma. Develop a asthma action plan with the PSCP and what to do if an asthma episode occur. Okay, so we should discuss with the PSCP if asthma is occur, what we need to do. So these all the things. Now we'll see the asthma triggers. So what are the asthma triggers? So we'll see this. Environmental factors. So main important is environmental factor. What is animal dander, cockroaches, cold and dry air, dust mites, exhausted fumes, okay, fireplaces, molds, perfumes, pollen grains, smoke, including cigarette or cigar, and sudden weather changes. So these are the main environmental. Okay. So in that also perfumes, this is very important, smoke is very important, pollen grain is very important, sudden weather changes, this is the main thing, and cold and dry air also. Physiological factors, exercise. So this is also important. When patient do exercise, he may lead to the asthma attack. And GERD also can be there. Hormonal changes, sinusitis also very important. Stress and viral upper respiratory infection also lead to the asthma. Medications, aspirin and all, acetyl salicylic acid, beta adrenergic blockers, beta blockers, and NSAIDs also. Occupational exposure, agriculture. The patient is a like farmer and also they may get the asthma attack. Industrial chemical and plastics, metal salts, pharmaceutical and drugs, wood and vegetable dust. Okay, food additives like beer, wine, dry fruits, shims, processed potatoes, monosodium glutamate, sulfamides, and tartrazine. So these are the food additives that this can also lead to the asthma attack. Now nursing intervention during an acute asthma episode is what we will do. So main thing I already told you, whatever respiratory problem we should provide the Fowler's positions, okay, or sitting position. The next one is administered oxygen. So position is first priority, then oxygen. Stay with the client to decrease the anxiety. Then administer bronchodilators or other nebulizers to treatment as prescribed. Record the color, amount and consistency of sputum. Administer corticosteroid as prescribed. Administer magnesium sulfate as prescribed. Administer intravenous fluid as prescribed. So whatever SCP will prescribe, we will administer. Ausculted lung sounds before, during, and after treatment. Okay. So before treatment, during treatment, and after treatment, we should auscultate the lung sound. Okay. Now next topic we will see the COPD. Next topic is COPD, that is chronic obstructive pulmonary disease. So it is also known as chronic obstructive lung disease. So we can say COPD pulmonary disease or COLD, chronic obstructive lung disease, or chronic and chronic airflow limitations. Okay. So what is that? Chronic obstructive pulmonary disease is a disease state characterized by airflow obstruction. So obstructive, with the name itself we can know this is a obstructive. Chronic means for a long time. Pulmonary related with the lung disease, any disease. Okay. So chronic for long time, obstructed matlab this is a obstructed disease of the pulmonary function. Okay. So it is a disease characterized by airflow obstruction. Okay. So there will be the two main condition in the COPD. So what are the two main condition? One First one is chronic bronchitis. Another one is emphysema. So there will be a chronic bronchitis and emphysema. These both together are called COPD, are progressive lung disease that fall under the general category of the chronic obstructive disease. And chronic bronchitis is a condition in which the bronchial tubes becomes inflamed and excessive mucus production occurs as a result of irritants or injury. Okay, bronchial tube will becomes inflamed and excessive mucus production occurs. Okay, in emphysema, what will be there? Emphysema is a condition in which air sacs in the lungs are damaged. So in this, air sacs will be damaged and enlarged. So alveoli will be, what will happen? It will be damaged and it will be enlarged and resulting in the hyperinflation and breathlessness. Okay. Progressive airflow limitation occurs associated with the abnormal inflammatory response of the lungs, and that is not completely reversible. So this is not a completely reversible. COPD to pulmonary insufficiency, pulmonary hypertension and cor pulmonale. COPD leads to, it will lead to pulmonary insufficiency, pulmonary hypertension and cor pulmonale. Okay. Then assessment. What we will assess? Any cough is there or exertional dyspnea can be there. So we'll check for exertional dyspnea, wheezing or crackle sound, sputum production, weight loss, barrel chest. So this is the main characteristic feature of the emphysema. Okay, so there will be a barrel chest in emphysema. Patient will use the accessory muscles for breathing. Prolonged expiration can be there, orthopnea can be there, cyanosis can be there, delay capillary refilling, finger clubbing will be there. Okay, cardiac dysarrhythmias can also be there. Then congestions and hyperinflation seen in chest X-ray. So there will be a congestion in the chest X-ray. ABG will check arterial blood gas levels, indicate the respiratory acidosis. So this is also important in COPD. There will be a respiratory acidosis. Why respiratory acidosis? Because the carbon dioxide will increase in the COPD cases. Okay, so that's why respiratory acidosis will occur. Respiratory acidosis with or without compensation and hypoxemia will be there. Uncompensated respiratory acidosis in a COPD patient generally indicates acute exacerbation of the COPD. Okay, uncompensated respiratory acidosis, what will it indicate to? Acute exacerbation of the COPD. Next one is pulmonary function test demonstrate a decreased vital capacity. In pulmon, when we do the PFT, it will demonstrate the decreased VC, vital capacity. So what are the interventions we can do? We can monitor the vital signs. We can administer the oxygen based on the ABG values and oxygen saturation. Monitor the pulse oximetry. We can go for chest physiotherapy. Instruct the client in a diaphragmatic and abdominal breathing techniques, tripod positions, pursed lip breathing. So this is a very important thing. Okay, diaphragmatic. Okay, diaphragmatic abdominal breathing techniques, diaphragmatic and abdominal techniques, tripod positions, and pursed lip breathing techniques, which increase the airway and keep air passes open, promoting maximal carbon dioxide expiration. So it will lead to the what? Main thing, it will lead to the to remove the carbon dioxide. So pursed lip breathing will help to remove the carbon dioxide. Okay, and record the color, amount, and consistency of the sputum also. So this is the barrel chest. Okay, this is a barrel chest. We can see in the COPD. we can see in the emphysema. So this is a normal lung, okay, and this is a chronic obstructive. This is a hyperinflation of the lung, flattened diaphragm, okay. Then record the color, amount, consistency of sputum. Then suction the client. Suction the client's lung if necessary to clear the airway and prevent infection. Monitor the weight. Encourage small frequent meals to maintain the nutrition and prevent dyspnea. Provide high calorie, high protein diet, okay, with supplements. Increase fluid intake up to 3000 ml per day. So per day 3 liter fluid, okay. Keep secretions thin unless contraindicated. Place the client in follows position and leaning forward. Weight breathing. Allow activity as tolerated. Include exercise conditioning and pulmonary rehabilitations to prevent muscle deconditioning. Assess the physical limitations. Develop activity plan. So these all things we need to do. Administer bronchodilators, other nebulizer as prescribed. Instruct the client use of oral and inhalant medication. Administer corticosteroid as prescribed. Administer mucolytics. Mucolytics will thin the secretions. Okay, like mucomix and all. No, acetylcysteine we use acetylcysteine. So acetylcysteine we use. It is a for nebulization we use acetylcysteine. Okay, and it is a antidote for PCM. This is an antidote for PCM. Okay, administer antibiotics. Okay, administer antibiotics for infection if prescribed. Then client educations. So client educations, what we will teach the client. So this is the client education. Client education for COPD. Adhere the activities and limit. Adhere the activity limitations, alternating rest period with activity. Avoid eating gas producing foods, spicy foods, and extremely hot and cold foods. Avoid exposure to individuals with infections and avoid crowds. Avoid extremes in the temperature. Avoid fireplaces, pests, feather flows, other environmental allergens. Avoid powerful odors like perfume and all. Okay. Meet nutritional requirements. Receive immunizations as recommended. Recognize signs and symptoms of respiratory infection and hypoxia. Stop smoking. Use medications and inhalers or nebulizers. Use oxygen therapy as prescribed. Use pursed lip and diaphragmatic and abdominal breathing. When dusting, use a wet cloth. Okay, so these all things we need to teach the client. Now next topic we'll see the pneumonia. Okay, so what is pneumonia? Pneumonia, infection to the pulmonary tissues including the interstitial space, alveoli and the bronchioles. Okay, so it is the infection of the pulmonary tissues including the interstitial space, the alveoli and the bronchioles. Okay, the edema associated with the inflammation stiffness of the lung, so there can be an edema. Okay, so there can be edema and decrease the lung compliance and vital capacity and causes the hypoxemia. So pneumonia is mainly is inflammation of the lungs, okay, which decreases the compliance and vital capacity of the lung and it will lead to the hypoxemia. Pneumonia can be community acquired or hospital acquired. So it can be a community acquired or hospital acquired. The chest X-ray film shows lobular or segmental consolidation. So consolidation will be there or pulmonary infiltrates will be there. This is the position we can provide for the COPD. And a sputum culture identifies the organism. So in sputum cultures we can see the organism. Okay. So it can be a bacterial pneumonia or viral pneumonia like that. Okay. The white blood cell counts, procalcitonin and erythrocyte sedimentation rates are elevated. So WBC will be increased. Okay. Procalcitonin will be increased and ESR will be increased in the pneumonia. Then assessment, how we will assist. Chills can be there. Okay. Elevated temperature can be there. And other vital signs we need to check. Pleuritic pain will be there. So there will be a pleuritic pain. Myalgia can be there. Tachypnea, tachycardia. So breath sound is wheezing and rhonchi. Uses of accessory muscles for breathing and dyspnea can be there. So these are all things we need to assess. Cyanosis, especially around the mouth or conjunctiva. So this is a very important. So cyanosis can be there, especially in the around the mouth. In pneumonia, we'll see the cyanosis around the mouth or conjunctiva. Mental status changes can be there, sputum production and hemoptysis. Then what are the interventions we can do? So first, let administer oxygen, monitor respiratory status, monitor for labored respiration, cyanosis, cold and clammy skins, increase the encourage the coughing and deep breathing and use of incentive spirometry. So we can ask the patient do the spirometry. Use the client for place the client in a semi-folus position to facilitate the breathing and lung expansion. We should provide the semi-folus position for a client. Okay. Then change the client position frequently and ambulate the patient. Tolerate to mobilize secretions. Okay, we should ambulate the patient. Provide the CPD chest physiotherapy. Perform nasotracheal suctioning. We should do the nasotracheal suction. If client is unable to clear secretions, monitor the pulse oximetry. Monitor and record the color and consistency of and amount of the sputum. Provide high caloric, high protein diet and with the small frequent meals. Okay, so high calorie we should provide the high calorie, high protein diet. Okay, so that diet should be small frequent meals. Monitor IO charting. IO charting we need to do and encourage the up to 3 liter per day fluid. Okay, to thin the secretions. Provide balance of rest and activity, increasing activity gradually. Administered antibiotics as prescribed. Administer antibiotics, bronchodilators. If temperature is raised, so antibiotics can be given bronchodilators and cough suppressants, mucolytic agents, and expectorants. Okay. Prevent spread infection by hand washing and the proper disposal of secretions. So we should do the hand washing to prevent the spread of infections. And client education, what we will teach the client about the importance of rest, proper nutrition and adequate fluid intake. So rest, nutrition and fluid intake. Okay, so this is the main thing. Next is to avoid chilling and exposure to individuals with the respiratory infections or viruses. Okay, to avoid the chilling and exposure to individual with the respiratory infection or viruses. So patient any person is having respiratory infection, we should not go with him or we should we avoid that peoples. Avoid the smoke exposure. Regarding the medications, the use of inhalants as prescribed. To notify the PSCP if chills, fever can be there. If chills, fever, dyspnea, and hemoptysis increase and fatigue occurs, we should inform the PHCP. To receive the pneumococcal vaccine as recommended by PHCP. Okay, so pneumococcal vaccine patient should get. Okay, teach the client using proper hand washing techniques, disposing of respiratory secretions properly, and receiving vaccines, and will assist in the preventing the spread of infections. Okay, so these are the things we need to do. So for today's class it's enough. So next class we will see the respiratory severe acute respiratory syndrome. Thank you all of you. Study hard and to subscribe my channel, share these videos. Okay, thank you all of you.